My name is Morgan Goldsmith. I'm a registered nurse and director of clinical services for Hospi Corporation with the MACI catheter. Thank you all for joining us today. We're very proud to be partnering with Dr. Amanda Lovell from Optum's Hospice Pharmacy Services today, who will be presenting symptom management challenges at end of life. A little bit about Amanda. She is the inpatient unit clinical pharmacist at Optum Hospice Pharmacy Services. She graduated with her PharmD from Ohio Northern University, a fellow Ohioan, which I love. I'm located in Cincinnati, so not too far away. She completed her PGY1 pharmacy practice residency at Florida Hospital Celebration Health and her PGY2 pain and palliative care residency through the Ohio State University and Optum Hospice Pharmacy Services. Amanda, thank you so much for joining us today. I will turn the presentation over to you.
Thank you all for joining. Like Morgan said, I'm going to be talking about symptom management challenges at end of life today. So by the end of this presentation, my goal is that you'll be able to evaluate patients for medication and patient-specific variables that will help you select an appropriate route of administration for patients at end of life, and then also know how to select medications that can be used for multi-symptom management. This presentation is going to talk about dosing for medication as well as monitoring parameters, and I just wanted to let you know that these are intended for patients receiving hospice care, so dosing may be different for other patients. So to start off, I wanted to talk about some common symptoms in hospice. All of us clinicians who are taking care of hospice patients see these common symptoms as well as a lot of other inpatients. The ones I have started, I'm going to focus a little bit more on today, so dyspnea, pain, and nausea. These are symptoms that I very commonly see in the inpatient unit, as these are the patients that I'm dealing with most in hospice. These symptoms are also ones, that once patients are at the end of life and have trouble swallowing, that we may need to think about potential other routes of administration. This is a list of the goals of symptom management, and it includes things such as using medications efficiently, which include discontinuing medications that are no longer needed and not really providing benefit to the patient and can be worsening symptoms. We always want to make sure that we're using appropriate routes of administration, so we have to take into account what routes the medication can be given, and then balancing that with kind of patient-specific parameters and preferences. And we also want to make sure that we anticipate disease progression, so making sure that we kind of know what symptoms to expect in our patients and having appropriate medications in place for those symptoms. So when talking about hospice, we're really talking about supporting the patient's goals. So we're looking at patient preferences, which in regards to medications can be giving the patient and caregivers information about the medications that they're taking and the symptoms that they're experiencing, and using that to facilitate therapy choices and control. We also want to think about the medication. So are we using the medications efficiently? Are we discontinuing appropriate medications? Are we using medications that have multiple benefits when possible? We want to make sure we minimize side effects and always keep the medication schedule simple. When we think about our home care hospice patients, a lot of them have caregivers who are not medically trained, and so keeping the medication schedule simple can help them with administration of those medications. We also want to look at the patient's history. So look at their comorbid conditions, as that can affect what medications we use. Any allergies that they may have and those specific reactions to the allergies, as well as, again, anticipating the disease progression. So when we can balance the patient preferences, the medications, and the patient history, we're going to optimize the quality of life for the patient. This is a list of the different routes of administration that can be used for medications. Obviously, not all medications can be given via these routes, but this is kind of our choice of medication routes. Today, we're going to be focusing more on the oral, sublingual, rectal, and then some of the parenteral routes of administration. So when we look at all of these, it can be kind of daunting to select an appropriate route. So we always have to keep in mind that we want to think about what's cost effective for us, what is feasible for this patient. So are there certain routes that don't work? Like I mentioned before, at end of life, often patients are going to lose that oral swallowing ability. We also want to think about what the patient prefers. Is there something that's more comfortable for them? What's available in the setting? So when thinking about kind of our patient population, parenteral routes of administration are not always going to be feasible in the patient's home if there isn't a caregiver who can administer the medication via those routes or be taught to administer the medication via those routes. And then we also just want to think about what medications are truly needed based on the patient and the symptoms present. The next few slides, we're going to compare some different routes of administration and talk about various pros and cons of these routes. So when we think about the oral route, this is kind of the traditional way that medications are given. Most medications are available in oral dosage form, and a lot of the studies about medications were originally done with the oral dosage form. It is definitely considered to be painless for most patients unless there is some kind of issue with swallowing ability. It is a convenient and safe route of administration. Easy to titrate medications via the oral route. We aren't as concerned about, their body composition in most cases. Oral route can have some cons, definitely. So it is difficult to tolerate in patients with nausea and vomiting, and there are a lack of available liquid options. So this can limit the use in patients with dysphagia. Thinking about the sublingual route, again, it is typically considered to be painless, but with some non-buffered or acidic solutions, there may be some burning or irritation that's possible. You may have to add water or wet the tablets if the patient has a dry mouth because they do need that saliva to truly get the medications absorbed sublingually. There is definitely a limited volume that can be administered comfortably with sublingual administration. So we're thinking about, a max of 1 to 2 mLs at a time for sublingual administration. Not all medications are absorbed sublingually. So even some of the medications that we typically give sublingually, like morphine, actually most of the absorption we get is from the medication trickling down the throat. Medication absorption can vary in sublingual administration. So there are some medications such as furosemide where if you can truly hold the medication under the tongue for several minutes, you're going to get more absorption than if the medication is just able to be held for a minute to seconds. Rectal administration is definitely a route that we use commonly in hospice patients. One thing about rectal administration is we must consider patient preference and privacy. So some patients may be opposed to using the rectal route of administration. Rectal route can be used for both local as well as systemic effects. Absorption via the rectal route can be variable based on the medication that we are giving. This can be very, very useful when patients are unable to swallow or if they have significant vomiting that is kind of cutting off that oral or sublingual route of administration to us. Some medications don't have literature to support rectal administration. However, the data for rectal administration is definitely growing at this time. For the transdermal route, it is considered a painless option. It can be very difficult to titrate because of long titration intervals for many medications. Most patches cannot be cut or folded, so that's going to limit the areas that we can place the patches in. And patients with multiple different patches do have an increased risk for medication errors, just getting confused about which one should be taken off at what time and what should be replaced. Not all drugs penetrate intact skin, so transdermal route of administration is not appropriate for all medications. This last slide here is going to look at the parenteral routes of administration. So we're comparing the intravenous and the subcutaneous. Intravenous is considered the fastest and most reliable way of delivering a drug systemically, and it is suitable for large volume infusions. Intravenous is very easy to titrate and adjust doses, and we can do that very quickly if needed. This can be, again, useful if the patient has severe vomiting, but also if the patient has a bowel obstruction or questionable GI absorption. Intravenous is definitely an invasive route of administration, and some patients may choose to avoid this route. Additionally, intravenous can limit patient mobility, especially when we're thinking about patients that are on some kind of continuous pump that they would have to kind of roll around with them to be mobile. Thinking about subcutaneous, it is considered less painful than intravenous. However, some products, including steroids, can still cause some burning or tissue irritation with subcutaneous administration. The bioavailability of subcutaneous administration can be affected by the patient's body composition, hydration, and hydration status, and there is a limited volume per single dose. So again, we're thinking about a 1 to 2 mL at a time that we can give via this route. So how do we choose a route of administration? We really need to balance the availability as well as the patient preference. As far as availability goes, most medications are going to be available via an oral route of administration. Some are going to be available via inhalation, and then there are a few medications that come, as a transdermal patch. A lot of medications, again, are going to be available IV. It is kind of our most common of our parenteral routes of administration. A few medications can be given IM, and then most of the subcutaneous administration is actually an off-label use, as these medications were originally approved as an IV medication. Thinking about patient preference, oral and sublingual administration are going to be kind of the easiest for most of our patients. However, as the patients decline, there is going to be some kind of changes in the availability of those routes. Parenteral routes, we've talked about, IV can be very painful. Although subcutaneous is less painful, it still can cause some pain. And IM is typically considered a pretty painful injection. Looking at the rectal route, while it's not necessarily painful to the patient, some patients may just have a fear of using this route. And inhalation can be very burdensome just because of the time it takes to complete an inhalation, especially when we're thinking about a nebulized solution. This is a chart that's going to look at some of the common medications that we use in hospice. It is definitely not an all-inclusive list, but as you can see, most of the medications can be given via the oral route, quite a few via the sublingual route, again, quite a few via subcutaneous, and then most of these medications that we give can be given via the rectal route of administration. So before I talk about the medications, I just wanted to present a patient case, and we'll go back to this patient case at the end to kind of talk about what are some of our options for this patient. So PW is a 92-year-old male who is on hospice for lung cancer, but also has a diagnosis of CHF. He has a PPS of 20% and has been rapidly declining and having difficulty taking medications. Today, he's not able to swallow any of his medications whole, and he's presenting with increased dyspnea as well as edema. So looking at his medication list here, the majority of his medications are used for CHF and are maintenance medications. So he's taking aspirin once daily, lisinopril, furosemide, metoprolol twice a day. He also has an albuterol inhaler as needed for shortness of breath. And then for pain management, he is on the oxycodone extended release, as well as oxycodone immediate release for breakthrough pain. So before we come back to PW, I'm going to review some common medications for symptom management at end of life. Before I review these medications, it is important for me to talk about shortages. So many of our common parenteral medications have been in shortage during the last year. And kind of the one that is on the forefront of our minds at this time is the parenteral opioid shortage that is really affecting our hospice patients. This shortage does not have a necessarily end date in sight. A lot of the shortage is due to the hurricanes in Puerto Rico, and so that's going to affect our supply of the parenteral medications for a while. Some of the other medications kind of go on and off of shortage, so it's definitely not limited to the opioids that we need to be thinking about potential other routes of administration in hospice patients. So not only does the shortage affect our supply and the availability to get the medications, but it also can lead to price increases as well. If you ever have information or any questions about what medications are on shortage, the American Society of Health Systems Pharmacists does keep a current drug shortage list, which is a good reference point. So looking at this common medication list, we're going to go through several medications, and this chart is just helping us to kind of visualize what these medications can be used for. Like I mentioned, when we're talking about patients who are having difficulty getting medications, it's best to use medications that kind of have multi-symptom benefits. Not all of these medications are going to work for all patients, so we always have to take into account patient, family, and caregiver preferences, any medication allergies, drug-drug interactions that may occur, as well as any drug-disease interactions. And we want to make sure to individualize the medication choice to the patient and their family and caregiver. The first medication I'm going to talk about is haloperidol, which is a typical antipsychotic that is used for agitation, anxiety, and nausea, vomiting. It can be given via a multitude of routes of administration, and the starting dose is going to be the same for the oral, sublingual, rectal, IV, or sub-Q route. So we typically recommend a starting dose of 0.5 milligrams every 4 hours as needed. For each of these medications, I have included the adverse effects and monitoring parameters just for your information, but for time's sake, I'm not going to go through all of those. Some clinical pearls for the haloperidol is we do always need to assess for the underlying cause of agitation or delirium. So in a lot of our hospice patients, this could be uncontrolled pain that they aren't able to communicate to us. It could be things like uncontrolled constipation or anxiety, infection. So there are a lot of causes of agitation that we want to rule out before jumping to medications if possible. We do want to avoid haloperidol in patients with Parkinson's disease or Lewy body dementia. The antipsychotic that I recommend in place of the haloperidol for agitation is either using another sedative like a phenobarbital, or if we're talking about using an antipsychotic, our preferred antipsychotic is going to be Seroquel, just because it has a lower risk of affecting the dopamine levels. As far as a medication that we may use as an alternative in patients with Parkinson's disease or Lewy body dementia for nausea or vomiting, we can use promethazine as an alternative there, which can be given as a suppository or orally. Chlorpromazine is another typical antipsychotic that works much like haloperidol. The major difference between the two is the chlorpromazine is typically going to be more sedating than the low-dose haloperidol that we recommend as a starting dose. It can also be used for agitation, anxiety, nausea, vomiting, as well as hiccups. Chlorpromazine can be given oral, rectal, IV, or IM. We do not recommend for subcutaneous use, as there is some data that shows that there can be some tissue irritation here. The starting dose, again, is going to be the same between the oral and the rectal and the parenteral routes, and the dose is going to be 10 milligrams every 4 hours as needed. Moving on to phenobarbital, it is a barbiturate anticonvulsant, which can be used for agitation, insomnia, and seizures, and can be given via a variety of routes of administration. The starting dose here, again, is the same for the oral, rectal, and parenteral routes, and the dose is 30 milligrams every 4 hours as needed. Phenobarbital does have a long half-life, which allows us for the potential of once daily dosing in some of our patients. And it is important to note that it can cause a paradoxical stimulation in some elderly patients. So we should always monitor for that. Moving on to our anti-anxiety medications, lorazepam is a benzodiazepine, which can be used for anxiety, dyspnea, insomnia, muscle spasms, or seizures. Again, like the medications we've previously discussed, it is available in a multitude of routes of administration, and the starting dose here is going to be the same for the different routes of administration, with a dose of 0.5 milligrams every 4 hours as needed for anxiety or dyspnea. The dose for seizures is going to be different, kind of based on the patient presentation. Like I mentioned before, the conversion from oral to rectal to a parenteral route like IV is going to be a one-to-one conversion. Like with the phenobarbital, lorazepam can cause a paradoxical worsening of agitation, especially in our elderly patients with dementia, so we should be monitoring for that about an hour after dose administration. If we're using lorazepam for insomnia, the dose we need for insomnia is typically going to be 2 times the dose that we would use for anxiety. So if a patient is using a dose of 0.5 milligrams throughout the day as needed for anxiety and tolerating that okay, I would recommend a 1 milligram dose for insomnia, especially insomnia related to anxiety. I did just want to provide approximate equivalents here, as patients are very commonly converted from one benzodiazepine to another. So lorazepam 1 milligram is going to be equal to alprazolam 0.5 milligrams or diazepam 5 milligrams. Now we're going to discuss furosemide, which is a loop diuretic, which can be used for dyspnea or edema. Furosemide can be given via a variety of routes of administration, and the starting dose here is going to be a little bit different between the oral and rectal routes of administration and the IV or subcutaneous. So the oral bioavailability of furosemide is only about 50%, and so that's why there is that difference with the dose of furosemide orally versus IV or subcutaneously. We don't have a lot of information to kind of justify the bioavailability of the rectal dose, so I do recommend starting with this equivalent dose to the oral dose and then adjusting as needed for patient symptom control. In patients who have diuretic resistance with furosemide, we can consider rotation to an alternative loop diuretic. So I did provide, again, the equivalents here. Furosemide 40 milligrams orally is going to be equal to bumetanide 1 milligram orally or torsemide 20 milligrams orally. On the previous page, you may have noticed that furosemide had a nebulized form route of administration. So nebulized furosemide can be used for dyspnea, which is refractory to conventional therapies. So we want to use the injectable preservative-free furosemide and inhale that via a nebulizer. There's going to be minimal systemic absorption when we're using furosemide via this route, so there's not going to be a lot of diuretic effect that is reported. So as far as administration goes, we would mix the injectable furosemide solution with about 2 milliliters of normal saline and then administer that via a nebulizer. So now moving on to the pain medications. Morphine is an opioid, which can be used for dyspnea as well as pain and given via a multitude of routes of administration. The starting dose here for the IV and subcutaneous is going to be 2 milligrams every 1 hour as needed. And when thinking about the oral or rectal route, we would recommend a starting dose of 5 milligrams every 1 hour as needed. This is for an opioid naive patient. So if a patient is coming to us already on opioids, we would need to take that into account when calculating out their appropriate dose for symptom management. There are definitely a lot of concentrations of morphine, so that is helpful with subcutaneous administration because we are limited with volume there. For patients that are on morphine, we definitely want to use caution in patients with renal impairment because there is a risk of metabolite accumulation. So we need to monitor for signs of opioid-induced neurotoxicity, which can include allodynia or kind of abnormal responses to pain. So if a patient has a sheet on them and it's causing them a lot of pain, that could be a sign of neurotoxicity. We also want to look for hyperalgesia, kind of worsening pain despite us increasing the dose of the opioid. And then we can look for myoclonus or muscle twitching that may occur with neurotoxicity. Oxycodone is another opioid which we commonly use in hospice patients for dyspnea or pain. It is not available as a parenteral preparation, so for routes of administration, we are limited to the oral, sublingual, or rectal routes. The starting dose for oxycodone is going to be 2.5 milligrams every 1 hour as needed for pain. Oxycodone does have a lower risk of neurotoxicity than morphine or hydromorphone and may be our preferred agent in patients with renal impairment. I just included this chart for completeness sake. This is an opioid conversion chart which kind of compares the doses of sub-Q and IV to an equivalent oral or rectal dose. So we would want to use a chart like this when we are switching from one opioid to another or one preparation of opioids such as a subcutaneous to an oral as those doses are not equivalent. The next medication that can be used for pain is dexamethasone, which is a corticosteroid. It can be used for fatigue, inflammatory pain, or dyspnea. Routes of administration here include oral, rectal, subcutaneous, IV, or intramuscular. However, I did note before that there could be some burning with that subcutaneous or IM injection. The starting dose is going to be 4 milligrams, and that is the same for the parenteral as well as the oral and rectal routes. And we do recommend administering dexamethasone in the morning just to avoid some of the insomnia associated with corticosteroid use. There is less edema with dexamethasone than prednisone or methylprednisolone. So in our patients with CHF or just to have a lot of edema, this is typically our preferred corticosteroid. Prednisone is another corticosteroid which can be used for fatigue, inflammatory pain, or dyspnea, and given via the oral route of administration. There is a typo here, so the starting dose is actually going to be 20 milligrams once daily in the morning oral as opposed to the 4 milligram dose. So going back to our patient case, just to review, PW is a 92-year-old male on hospice for lung cancer with a diagnosis of CHF who is rapidly declining and no longer able to take his oral medications. So looking at this medication list, what medications are not necessary for PW at this point? So looking at this list of medications, I see a lot of kind of maintenance medications. This patient has a low PPS score of 20%. He's rapidly declining. And so at this point, when the patient can no longer swallow these oral medications, we have to kind of evaluate if they're appropriate to continue. So, looking at this patient, I would recommend discontinuing the aspirin, the lisinopril, and the metoprolol. With the furosemide, we did report that the patient had edema, so I want to continue it, but the oral route is maybe not the best at this point as he can't swallow the tablets. And now we have to think about what symptoms do we need to address. So we need to address dyspnea, we need to address edema, and we also need to address the pain the patient's having. because we know that those oxycodone extended release tablets can't be crushed, so the oral route is out for the oxycodone as well. So what medications could we use to manage these symptoms? As far as the dyspnea goes, we could use morphine or oxycodone. Either would be appropriate in this patient. We don't have, a history here listed of chronic kidney disease. So really an immediate release opioid. We could also use lorazepam for dyspnea. And then, as we mentioned before, nebulized furosemide could be used. For edema, we could use the furosemide, like I said before. We just need to think about an alternative route here. So keeping in mind that medication shortage, we may not want to use those parenteral opioids. This patient was on oxycodone. He was well controlled on his oxycodone. So instead of switching to like a parenteral morphine, we could just think about giving that oxycodone via an alternative route. And although, there aren't as major of shortages with lorazepam and furosemide right now, if we're kind of sticking with one route of administration, that may be better than having to, use a rectal route of administration for the patient and using IV when we could give these medications via the same route. So looking at this patient's regimen, what I did was, when coming up with his regimen, was I took that oxycodone extended release, which was 60 milligrams every 8 hours, and I knew that I couldn't use the extended release preparation via a rectal route of administration. The oxycodone extended release is an abuse deterrent formulation, so we don't want to give that tablet rectally. So I looked at the regimen and I split it up into oxycodone immediate release. So I just took the dose and I dosed it every 4 hours, which is about how long that immediate release preparation is going to last. So oxycodone 30 milligrams, 4 hours around the clock. It's simply just to replace that oxycodone extended release product. We could also do oxycodone 15 milligrams rectally every 1 hour as needed for pain or shortness of breath. This is no change from the patient's previous order. We're only changing the route of administration. The dose did not need to change. For lorazepam for dyspnea, the starting dose here is going to be 0.5 milligrams every 4 hours as needed for anxiety or dyspnea. And with that furosemide, the patient was on 40 milligrams oral, so I would recommend 40 milligrams rectally once daily in the morning for the treatment of edema. As opposed to that inhaler, which may be hard for the patient to use as he declines, we could use the albuterol nebulized solution via nebulizer every 4 hours as needed for shortness of breath. So because this patient is getting so many rectal administrations, especially with that Q4 hours around the clock regimen, this is a patient where I would recommend the use of a MACI catheter, especially if the hospice has one available in this kind of immediate situation where the patient has rapidly declined, because that is going to save us from having to administer these frequent rectal routes of administration. Instead, we can place the catheter and just use that to get the frequent doses. So just to summarize, as the patient declines, the oral route may no longer be an option for symptom management. We do need to consider patient-specific and medication-specific variables when choosing an alternative route. So not all medications can be given via all routes of administration. We do need to choose medications with potential for multi-symptom management when possible, just to limit the number of medications we're having to give the patient. So with that, I will open up the floor to any questions you may have. On the screen, there is the information for the MACI catheter support. So there is the website information, email, as well as the clinical support telephone number.
Great. Thank you so much, Amanda. Really appreciate it. We also on the line have Dr. Bridget McCrate-Protis, who has been, she's the Director of Drug Information, works closely with Amanda, and has been answering questions as you go through all the information, Amanda. So majority of questions that have been submitted at this time have been answered. However, Dr. McCray, I'm going to unmute you here. Is there anything specific that you've been asked that you'd like to share with the group?
Well, let me think about that. There certainly have been some interesting questions, and I would say, you know, Dr. Lovell can respond as well. I don't know if you have a chance to open them. One of the questions, an interesting one, was submitted about the truth to, or the thoughts on sublingual medications being absorbed quicker than medications that are then allowed to swallow down the back of the throat. And that's a common misconception among a lot of clinicians, actually, that just because a medication is given sublingually doesn't mean that it actually absorbs sublingually. But some are specifically designed to be sublingually administered and are well absorbed that way. So, for example, in my response to the person who requested or was asking that information is nitroglycerin tablets are designed to be very small, readily dissolve and absorb quickly across the sublingual mucosa, sublingual tissue, so that you have that immediate onset of action to relieve the angina that the patient might be experiencing. So that's an example of a sublingual dosage form that readily crosses that tissue and is absorbed from the sublingual space directly. Whereas morphine or Roxanol, the 20 milligram per ml oral concentrate, is actually conveniently placed in that sublingual space because it's a very highly concentrated dosage form, so that we can give folks who have very difficult swallowing ability or need maybe a larger dose, a pretty small volume that we can give with limited active participation of swallowing. So as the patient begins to have dysphagia and is having difficulty at the very end of life, we can give a dose. We'll expect maybe about 20% of that dose to be absorbed from the sublingual space, and the rest of it will trickle back and be swallowed as a normal PO dose. So what's never actually been studied is how much of a quick symptom relief boost the patient might experience from that initial percentage or fraction that is absorbed from the sublingual space. It would be a great clinical trial, but it would be a difficult one, I think, to do. But that's a question that's not known. My guess is that there's certainly an expectation when sublingual medications are given that they have a fast onset of action. So it may be that patient's expectation as opposed to actual clinically significant absorption. You know, but there are medications for pain, such as fentanyl lozenges or fentanyl mucosal absorption products that do readily, again, cross the mucosa of the mouth and absorbed immediately from that space. Fentanyl is one that if the person chews the lozenge and swallows it rather than waits for it to absorb in their mouth, they'll actually lose some of the effectiveness of the medication because fentanyl does not absorb well or can be destroyed. The drug is destroyed in the GI tract. So it really is, it's an understanding of pharmacology and the way the dosage is actually formulated. And do you have anything to add, Dr. Lovell or Morgan?
No, and along those same lines, we did have another question of, can the crushable oral meds be made into a slurry and put into the buccal tissue? And so most products that are crushable, we can do that, but along the lines of what Bridget was saying, those medications may not actually be absorbed in the buccal tissue or sublingual. We may be getting some of the effect by the medication trickling down the throat. So that's going to depend medication to medication, but medications that I did recommend getting sublingually, those immediate release crushable oral meds can be used to treat that.
Great. Well, thank you. We have received quite a few questions on access to this presentation. So just so everyone on the call is aware, we will have this recorded, or this presentation is being recorded, and we will have it available probably early next week. So if you're interested in sharing or viewing again, we will be sending out information on how to access that presentation. Again, it should be ready to go by first thing early next week, and we'll make sure to get all of that contact information to you all. One of the questions that we received during the registration process was that specific to medication delivery via the MACI catheter. And that was, if I want to find out what drugs can be given via the MACI catheter, where can I go? So Amanda, I'll let you share a little bit about the Optum medication algorithm.
Yeah, so we do have a document located on macicatheter.com. If you go to product information, there'll be a few documents there, but the one we're specifically referring to is the Optum medication algorithm. And so this algorithm, I can actually share my screen. I have it pulled up here. So this algorithm kind of looks at the guidelines of when we would consider the use of the MACI catheter or traditional rectal route of administration. So like I mentioned before, our go-to route of administration for most medications is going to be the oral or sublingual route. But when that route fails, we have to look at, can the medications be given rectally, yes or no, and initiate the best choice for the patient. So whether that be the MACI catheter, especially if you have access, or the traditional route. And so that's going to be kind of based on patient or caregiver preference, as well as the caregiver abilities. And then from that, we want to see if symptoms are controlled and potentially thinking about other pathways for refractory symptoms. So this does have this quick chart that I used in the presentation that looks at crushed, sublingual, sub-Q, rectal, or MACI catheter. But on the second page of this, it goes through many of the common medications that we'll use in hospice and talks about, can you give them rectally and with the MACI catheter? And as you can see, a lot of the answers here for medications are yes. A few common medications that you cannot give because there is just poor rectal bioavailability are things like gabapentin, glycopyrrolate, which can also not be given sublingually. And then phenytoin as well cannot be given via the rectal route. But as you can see, as I kind of scroll through here, most of the other medications that we commonly use do have information for rectal route. This is definitely not an all-inclusive list of all medications we may use, but it does touch on the common medications.
Thank you. And this is a great resource. We actually have this posted on our website, macicatheter.com, under product information. If you're interested in accessing, you can also get it through Optum's website. This is a great resource to download and have as a quick guide. The next question is MACI catheter specific, and it actually talks about the device and just says if the catheter were to come out with a bowel movement, can the same one be reinserted? So a little off the drug discussion, but wanted to address it, especially because it was just asked throughout the presentation. The answer is yes. So the catheter is indicated to stay in place in the same patient for up to 28 days. However, if it were to be expelled with a bowel movement, which is actually designed for the balloon to come out with a bowel movement, the catheter would simply need to be wiped down, the balloon would be deflated, and then you'd be able to reinsert that catheter if it was in that 28-day period. The second part of that question is, can the family be taught to do this? So the initial insertion needs to be by a clinician, but if approved by your agency, then the clinicians are able to teach family members and caregivers to be able to insert the catheter for it to be expelled, and of course give medication through the catheter as well. So thank you so much for that question. It looks like, I believe we've gotten to the majority of questions at this time. Amanda, anything that you'd like to close with or say as we wrap up the presentation today?
I don't think so. I just wanted to, again, thank you all for attending the presentation.
Wonderful. Thank you. Bridget, anything?
Well, one thing I wanted to note, there was a question about the drug shortage slide, and I provided that in the answer, and it's also in Amanda's slide, or Dr. Lovell's slide pack, which you'll see when you download a copy of the slides. It's a free resource. You do not need to be a member of ASHP, which is the American Society of Health System Pharmacists, to access that information. They provide it as a service for all clinicians, and it's very well up to date, and it also provides information on alternatives if the product you're looking for is not available because of a shortage. That also kind of leads me into, and Dr. Lovell mentioned this as well, one of the benefits, I think, of the MACI catheter, apart from it kind of bypasses that patient humility or privacy issue with traditional rectal administration processes, but in this time of shortage of injectable opioids, we're seeing, unfortunately, we're seeing hospitals go back to injectable meperidine or codeine or injectable opioids that I would not consider the safest, best option other than an extreme emergency that it's happening right now with injectable opioids. We're seeing really good results with making recommendations to give the opioid rectally via a MACI device if that's available to you. So think of it as an alternative. I know inpatient units are using it now and seeing good results. And it's a way to make use of the opioid that is readily available. The oral dosage forms are not in shortage at this point, but the injectables pretty much all are. And so even if you can now maybe swap to one, some hospices have been swapping patients between morphine, then injectable Dilaudid, then injectable fentanyl, and then back to Dilaudid based on what their hospital system can access. I think we're kind of uniquely positioned to be able to access this device and use it for rectal administration and see similar symptom management results with opioids too. So we're using an oral dosage form. We're not impacted by that injectable shortage, and we can still manage patient symptoms.
Great point, and thank you so much. We have had many agencies reach out to us, and some fairly large agencies recently as a result of the shortage, and it's been pretty incredible to see the impact of even just switching over practice to using some of the oral forms, specifically in the IPU, and how effective it's been for those organizations. So if anyone is interested in continuing that conversation or is interested in learning more about the MACI catheter, please feel free to reach out to us. And again, there'll be a follow-up email after this webinar with our contact information where you can just reply to that, and we'll get back to you and continue that conversation. Real quick, Bridget or Dr. Lovell, there was a comment about downloading slides. If someone's interested in downloading the slides, where could they find that? I know that will be part of the Optum excuse me, website.
The slides from today's presentation?
Yes.
Okay. I'm trying to think of a good place so we can post them on our site. We can post them through our Optum Hospice page, through probably the public access CE seminars registration link. So look for them there.
Great.
Sorry, I don't have a specific address because I don't manage the website, so I'm not sure where that would be posted exactly.
No problem. I'm sorry. I misunderstood. But thank you for that information. I believe Susan asked that question, and Susan, I'll make a note that we can follow up and make sure that we get you that information. Received one more quick question. How easily can the MACI catheters be managed in the home? A big question, but simple answer, and the answer is very easily. Without getting into the full story, the MACI catheter was actually invented by a hospice nurse, Brad Macy, who was working after hours in the home, and he created the product to be able to manage symptoms in the home when patients started to lose the ability to swallow. So I would say we have a large presence in IPUs, but even bigger presence in home care settings. So thank you for that question. All right, well, it looks like the majority of questions have stopped coming in. Amanda, Bridget, thank you again for your time. We really appreciate being able to partner and be able to share this information with the hospice community. And we'll look forward to answering any questions. If you have anything from all the participants on the webinar, please feel free to send those to us, and we'll make sure to get you a response. But thank you again, and I hope everyone has a great week.